talk to you about central line dressing changes today. And anatomically, the reason why they're called central is because the other end of this catheter is sitting centrally in the vascular system, usually right there at the junction of the superior vena cava and the right atrium. So if you can imagine, that can be kind of a serious location, so we take this very seriously. Clamping, we don't want to introduce air. Air is going to be introduced if the clamp is open, nothing is covering the end, and that's bad, because if you get air in your pulmonary capillary area, you die. So it's an air embolus. No embolus is good, no matter where it lands in the body. People can die. And I don't want it to be your fault if this occurs. So you can also have what they call a peripherally inserted central catheter. Peripheral, it's inserted in the peripheral area, but this is long and it does go all the way up and is usually sitting right there in the superior vena cava or subclavian vein junction area. And those are placed by nurses that are trained and certified. Now, in the hospital setting, depending on where you're at, some of the nurses are trained to remove these. The vascular team would be the ones that go get certification for this. So if you're with a nurse and she's allowed to DC a PICC line or a central line, you can watch and assist, but you may not do that in the hospital setting until you've been trained properly. Alrighty, so get supplies here. And if you looked at the skills photo album, you kind of already know what they should be. Your patient needs a mask. If you're claustrophobic, these are the best masks to wear. And I think our little guy here is. So your patient's going to need a mask because what they breathe out can infect that when the dressing is off or when this is open while it's clamped and you're changing out the end cap. Your saline flush, your end cap, and you're going to see different kinds of those, but they're basically all positive pressure. Need your hand hygiene, of course, and you're going to have to do that in between clean gloves and dirty gloves. And I will tell you, this guy's dressing is probably not going to come off easy, because after they've been on for a while, not a real person, of course, but on these guys, it takes a while, so I'll probably cut that part out. Now, as you well know, you need to have a mask on before you remove that. Now, you can choose to clean this part and change out your end caps beforehand, which I personally like to do. The wrong way is if you cause harm to the patient or if you contaminate the patient. Now, the goal is for these centrally located, they may even be in the groin area, in the femoral vein. The goal is to get rid of those as soon as possible. So your mask is right on top of your supplies. So that's up to you if you want to grab the mask that you bring with you, if you want that for yourself, or if you want that for your patient. Now try not to touch the inside of this when you're getting the mask, but if you can save this so that the middle is still sterile, then you've got another little sterile field. But it's wax paper, so if you push down and lift up, then you can grab one of those folds and not contaminate your supplies. And you know the drill. You're going to be talking to your patient, you're going to do your AID-IT. put your mask on. There's really no concerns about splash. With this skill. Main thing we're looking at is if you're being safe while you're doing this skill. So I'm going to actually take care of my end cap first. And since this guy doesn't really have a vascular system underneath, we're going to pretend that this is my saline syringe. So I'm actually going to lay that there so I don't contaminate the end of that. Now in the hospital setting, every central line needs to have one of these Kuros caps on it. They have to be on for 3 minutes before you use that port. And it's just a sponge inside that's saturated with alcohol. So ideally you should have one of those on there. So you're going to bring your new end cap, and just be careful when you open it, and that way you don't have to worry about putting one of those green things on before you attach your syringe. So again, attach your syringe, that's sterile to sterile. And then you still have that end covered, so just you can set it aside. Now, for the purpose of this skill, you need to be sure you verbalize that my clamp is clamped. Okay, when you're talking to a patient, of course you're going to say your clamp is clamped. And then we can remove this, but open your alcohol pad first. Because what we're going to do is we need to clean the threads underneath. So my clamp is clamped. You're going to remove the blue end cap and this old green Kuros. Take your alcohol pad and you're going to scrub those threads for at least 30 seconds. So it's been 30 seconds. Go ahead and clean this other part as well. Now we can put our new end cap on. I'm going to take the cover off that goes on the central line access. Has a little white port, just put it in there, twist, make sure you get it secure, and you're going to, once you know that you have it twisted down, you got to open that clamp. You will aspirate back to see a little bit of blood return, and then you're going to flush, and the way you flush is a push pause. You want to create agitation, because where that end of that catheter is sitting in that superior vena cava, right atrium area, it can build up some thrombin and stuff if you're not knocking all that off, and you just pulled a whole bunch of clotting factors up when you check for placement. So you're going to do a push pause, push, 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 push. Don't go all the way to the end. Leave it like a ½ ml in the syringe, because what happens, put that down, if you push all the way down and you let go, that rubber in the plunger re-expands and creates negative pressure. So you always want to leave at least a ½ ml in there. So we're done with that, so we can disconnect and toss that. And then we're going to put a new Kuros on this new end cap. So now I'm going to take an alcohol pad and I'm going to clean the outside of this tubing. Now there's a piece of tape here to kind of secure it so it's not flopping around, getting in the patient's food. So we're going to clean this and start where it comes out from underneath the dressing, and you're just cleaning. Go up, not down, towards the site when you're this close. Clean around that clamp. Make sure you get that clamp clamped unless you have something infusing in there. When you're done flushing. Okay, so I got that outside part cleaned, and at this point I can go ahead and put my new piece of tape on if I want. But what we want to do is we want to assess the site. So I do this with the dressing still on, and you're looking for redness, edema, drainage, that kind of stuff. So, and you may not see any drainage until you actually kind of press on that close to the insertion site, and that's what you're looking for. Now with the bio patch in place, you're not going to be able to necessarily see that, but with the bio patch, it has antimicrobial in it, and it will help prevent, it's got the chlorhexidine, it'll help prevent that central line infection. So we really want to avoid that central line associated bloodstream infection. And my tape is right there, so I can grab it without contaminating my kit. And get that part off. And this is just so it doesn't fall down when we're working with it. And I like to pinch around the tubing itself and then lay it down. Make a little splint. And that way it can move around and it has some play in it, but not enough to cause harm to the patient. Okay, at this point we are ready to take that dressing off. And if it's real sticky, you can use silicone-based adhesive remover, but we don't have any of that. So we can use our alcohol foam to kind of get this working up. So for the purpose of a lab, I've made some larger bio patches that are going to come off of there a lot easier. Okay. Don't throw your little baggie away or your fake bio patch. Just saying. Okay, so I'm going to remove this dressing. Stabilize the insertion point as I pull towards it. Remember, you're assessing the condition of the skin. And you'll know that since it's a transparent dressing. So you'll know if you need to bring any skin barrier or skin protectant. Now this bio patch is kind of tricky on a real one to get off of here. Hasta la vista, baby. All done with the removal thereof. Skin is beautiful despite having to get rough with that dressing. Okay, so I'm done with my clean gloves. Remove your gloves. What do we do after we remove gloves? Hand hygiene. And that's a golf ball size. Of course, you're going to be talking to your patient the whole time. Again, the gloves in the packages seem to be about a size medium. They're vinyl, not real stretchy. So if you know that you normally have problems with these type of gloves, remember you can reach up inside there if you need to straighten things out. You're just not touching the outside of that cuff, just the inside. Now, same thing with the sterile one. If you need to get it adjusted, I'll show you over here. So like if it's being really sticky on the cuff, protect those fingers. And you can come over here and manipulate and straighten if you need to before you try sliding your hand in there. That'll help you decrease the amount of contamination that you might do. Yay! So the only thing we need sterile hands for, and on those bio patches you can do it with one hand, is the bio patch itself. Because everything else, see, like this, even is 1 inch away from the sponge. So those, you squeeze those together, milk it down, make sure the sponge is wet before you start scrubbing your client. I like to start with the center, do my horizontals, working out and away. But with chlorhexidine, you can go crazy from all directions. But, you know, when you get set in a mode where you always do the HVAC, then just keep with that. So now I'm going to switch to my vertical. And then I'm going to start with my concentric. I want to try and get the tube with one pass. And the top side of those sponges are pretty wet, so it's getting the bottom side of the line. You just want to make sure you do a minimum of 30 seconds. Okay. So ideally you're waiting until that dries. The bio patch, a roll on, is about a dime size. I make these large and easier to handle until you get your dexterity down pretty good. And they go up and they tell you exactly how to put them on. And you're just basically saddling it around that catheter. Okay. So you're basically done with what you needed to be sterile for, was pretty much that bio patch. Because the part of this dressing that touches the patient is covered and will remain sterile until you contaminate it. Hopefully not. Anyway, so you can just pull that off, and you can redirect this catheter if you want to. That's up to you. So we want to try and avoid getting too much of the nipple underneath this dressing. And we want to make sure we have at least a 1 inch border around the insertion site, which, as big as I made the bio patch, you have that. So you also have a label on this border, so make sure you save that so that you can label your line. But you want to make sure that you don't obscure the path of that tunneled catheter when you do apply that. I like to pinch the dressing around where the line goes in under that dressing. And if it's not in the path of that line, then I also like to use this as another, the label as another securement device. So initials, date and time. And I just tear it if you need to. And then put it somewhere where it's not going to obscure the path of that catheter. Okay. So the goal of this, the goal of the chlorhexidine bio patch, is to help prevent CLABSI, that central line associated bloodstream infection, which is a problem because that is usually a hospital-acquired infection. If we can get rid of these more centrally inserted, it's like this one's tunneled. Tunneled means it goes underneath the skin in that subcutaneous tissue and then into the vein, superior vena cava. Whereas these go directly into, on the neck, internal jugular subclavian vein. is the access points for those. So there's not a whole lot of distance on that. And you'll see the examples in the lab. And if you have any questions, just shoot me an email or bring them with you to lab. And I think that is a final take. No phone calls during that one. Yay! So clean up, place your patient in a good position, take their mask off because they don't need it anymore.